Okay, if everyone wants to turn their screen on, we'll get started with class. Okay, Cassandra and Willette, if you guys could turn your screen on for me. So, um, I wanted to go over our schedule for the next couple weeks because, as crazy as it sounds, we're already almost halfway through the class. It goes really, really fast. So, next week is week 6, so we're at midterm already. So, I'm going to pull up our modules here on Canvas and we're going to review kind of what to expect in the next couple weeks moving forward. So let me share for you here. Okay, so we are now currently in week 5. So that means this week you guys have your second OB math assignment due by Sunday. And you also have your SIM chart preeclampsia assignment that is due by Sunday. You guys are more than welcome to send me your work for the OB math problems. I can review it for you and provide feedback. I will be providing feedback probably like Sunday or Monday, and it's going to be very similar to how I did that with the first assignment, where I'll go in and give you the rationale in the comment section for the questions that you got wrong. So you guys can be on the lookout for that like Sunday night, Monday night-ish. That's typically when we have to have our grades submitted once everybody has had time to complete them. Math was something that a lot of people missed points on the exam. So for exam 2, there's going to be another 5 questions or so of math problems. So I don't want you guys to miss points on math. So please, please take time to review them, take time to practice, because you're going to be seeing this probably on every test that you take in nursing school, and there definitely will be some on the NCLEX, okay? And just in nursing in general, you're going to be dealing with dosages and calculations and all of that stuff moving forward, okay? So that's what we're doing this week. You have your OB math and you have your preeclampsia sim chart assignment. Next week, okay, we have quiz number 4. Okay. So just like this week, we're going to get that started within the first 5 minutes of class. So please make sure that you guys are here on time because if you come into the Zoom late, or whatever, I won't be able to give you the access code and you'll receive a 0 on the quiz. If at any point in the semester you guys have to miss a quiz for whatever reason, um, email me and I will send you an appeal form that you guys will fill out at the end of the semester to be able to try and retake the quiz. Unfortunately, once the class time has passed, I'm not able to let you guys retake them because we only have access to it for that half an hour at the start of class 2, like 6 p.m., right? So you guys will have to file an appeal and wait until the end of the semester to submit that to potentially be able to retake your quizzes. Okay? So next week we have our quiz. Week 7 is our unit exam 2 already. It comes pretty quickly. So second exam will be in week 7. Okay? The other thing I want to point out in week 7 while we are here, you guys will not have access to this module, of course, until not this Sunday, the following Sunday. I want you guys to just have in your mind that you have 3 assignments that will be due in week 7 along with exam number 2. Okay? You're going to have a discussion post. You're going to have your SimChart external cephalic version assignment, and then you also are going to have this teaching plan assignment, which I'm not sure if you guys have heard about it or seen it or whatever, read about it. It is its own little mini project. I don't like to say project because it sounds like it's going to be like extraordinarily time consuming. The teaching plan really should not take you longer than about an hour or two to complete. We'll walk through it here briefly. I don't want to overwhelm you, but I do want to give you guys a good idea of what to expect in week 7 so that you can plan your schedules accordingly to give yourself enough time to study and also get these things completed. Okay? So when you have access to your teaching plan, you'll be able to pull up this page here. This is the assignment page. I want you guys to read through this very carefully as you're completing your teaching plan assignment. Basically, what you're doing is that you're going to be making a PowerPoint presentation, poster, video, or Word document that includes teaching on a preterm neonate, and it's focused on talking to like the parents. Like pretend like you're making this education for mom and dad. Okay? So you're going to need to develop a going home teaching plan that includes the following. And then these bullet points right here, you guys are exactly what I'm looking for whenever I'm doing your grades. Okay? So whenever you're making your assignment, whether it's a PowerPoint, most people will make a PowerPoint, to be honest. That's what I saw the most last semester. You guys are going to need to pay close attention to these bullet points and make sure that they are clearly defined for me in your assignment so that I know what I'm looking for and I know what to give you credit on. Okay? So you're just making a PowerPoint presentation that includes all of these things here focused on educating a parent of a preterm neonate who's going to be going home. Okay? Like I said, it should not hopefully take you too much longer than a couple hours to complete, but I always go over this in week 5 because I want you guys to be prepared because we have a lot during week 7. Okay? Where am I? Okay, so that's week 7. Week 8, we have our last quiz. Quiz number 5 will be in week 8. And then right away in week 9, we have our last exam. So that's when our unit exam number 3 will be, is week 9. All right, so the back half of the semester, I feel like moves very quickly, right? Because we don't have our first exam usually until week 4, right? So this is pretty quick. So we have an exam week 7 and then an exam week 9. After that is just HESI preparation, and you guys will take your HESI exams week 11. Okay. So we go over this now because, like I said, it moves very quickly. Okay. Anybody have any questions over quizzes? What to expect moving forward? Any of the questions on the assignments that are due this week? Okay. I have had a lot of students ask me about what how to know what to study for our quizzes. Okay. So I'm going to show you on our syllabus what I would recommend you guys following whenever we're talking about preparing for quizzes and preparing for classes. Okay. So in your syllabus, if you scroll down to, where is it? Here, our weekly course outline, you are going to be able to see, okay, we're in week 5. Here are the concepts we're covering. Here are the chapters of the material that we're following along with in the textbook. Here is what our key graded assignment is for that week and what your assignments are going to be, your homework assignments are going to be for that week. Okay. So as you're preparing for the quizzes, you should always know that the quiz is going to be covering content from the week before and the week of that you're taking the quiz. So this week was quiz 3. It was over a lot of stuff covered in week 5, and then also some review and some questions from week 4. So then when you're studying or you're looking at your syllabus, like, okay, what do I need to prepare or what do I need to study for the quiz in week 5? You're going to look at chapter 18, 19, 20, 21, 11, and 12 of your textbook. Okay, so that's how you can kind of follow along with the class and understand what you need to be studying as far as your quizzes so that you can be prepared for them. I think this course outline is very helpful in the syllabus. It gives you guys an exact breakdown of what you need to see and what you need to know for your quizzes. Okay. As far as like quiz content, I do not write the quizzes for our class, so I do not know the questions that you guys are going to be asked on your quizzes. Those are pre-made at the beginning of the semester by Professor McBride, and she uploads them into each module for each class. My biggest piece of advice for the quizzes is I would focus more on larger concepts rather than like smaller topics that aren't necessarily stressed during lecture or during class. Okay, that's kind of the best source of guidance I have for the quizzes, but like I said, I don't write them, so I'm not entirely even sure what the quizzes are asking you until after you guys are done with your quiz. Okay. I will be turning homework grades on, let's see, this Sunday or Monday. I'll be turning the weight of your homework on. So then you guys are going to be able to see what your total grade is in the class with homework and factored in. Okay, we turn that off, I believe, at the beginning of week 7 before your exam, and then it will not be turned back on until the end of term after you've submitted your HESI reviews and your HESI remediation whenever I'm submitting your final grades. So you guys can be on the lookout for that. I'll be turning on your homework weight this weekend. All right. Does anyone have any questions so far about any of the stuff that I just covered? Okay. Cassandra, can you turn your screen on for me? If you want, just go ahead and leave the Zoom until you're not in your car. Okay? And then you can join back in. Thank you. All right. So we're going to go ahead and finish up talking about our PowerPoint from week 4. Then we're going to go over our PowerPoint from week 5. My last class, we did not get to the activity that I had planned because we had a lot of content that we wanted to cover. So at the end of class, we ended up playing a Kahoot game for just like 10 minutes. So we'll probably do that if we have some time at the end. Okay. So let's go ahead and let me pull up our PowerPoint here. see if I can remember where we stopped. Okay, did we go through this slide, the what is your motive slide? Do you guys remember? No? Okay, let me see. Let's see. Did we go through this? Yeah. Okay. So we talked about if we have uterine atony, so our uterus, we're showing signs and symptoms of postpartum hemorrhage. What are our actions? What are our priorities? So we're going to want to massage our fundus, insert a Foley, administer Pitocin or other medications to try and get that uterus to contract and massage our fundus for sure. Okay. These are the four medications that we talked about. Did we get to the medications? Did we discuss those? Okay. So, we're gonna move on here then to what is our motive. So this is a really good way for us to remind ourselves, or a mnemonic for remembering the interventions that a nurse can do to help counteract uterine atony. Okay, so medications. We're going to administer the oxytocin, methergine, hemabate, or misoprostol. And we're also going to call our doctor. If your patient is bleeding, you definitely should be notifying your physician. We're going to administer oxygen because we want to make sure that they remain as hemodynamically stable as possible. We're going to assess for tone. So we're going to massage our fundus if it's not firm. If our fundus is not firm, the next question that we need to ask ourselves is, okay, if we know that this bleeding is not coming from the uterus, where could it be coming from? What is our source of our bleeding? So we're going to determine that. The other thing is we're going to prepare for an IV. We need two large bore IVs because we might be having to give blood. We need to start a second line of an 18 gauge or greater, and we obviously should be drawing labs. We're going to get our vital signs every 5 minutes and empty our bladder, right? Because we talked about how bladder distension can cause uterine displacement and can cause uterine atony. So we need to be careful about that. Okay. So Alyssa, age 26, had a C-section 7 days ago. She's breastfeeding her baby. She calls the office today and reports that she has a temperature of 102.4. Knowing Alyssa, knowing her background, what could be the cause of her fever? What are we worried about with this patient?
Infection.
Yeah, specifically from where?
Her breast, mastitis,
Mastitis. Yep, we can be worried about mastitis. What else?
Her incision site.
Incision site. Excellent. Yep. So these are the four main infections that we worry about when we talk about postpartum patients: endometritis, mastitis, cystitis, and then an incisional or surgical site infection. Okay. um, why, for Alyssa, are we specifically worried about a UTI with her? Why are we extra nervous about her developing a UTI?
she had a catheter from the C-section.
Yes, exactly. She had a catheter. Okay. And we also have to think about, like, after a C-section, is this patient ambulatory right away at least? No.
No.
No, she's not. So after a C-section, because these patients they get a spinal epidural or spinal anesthesia. Sometimes they have an epidural or whatever. So they are not getting up out of bed until about 5 to 8 hours after. Okay. So if they have a catheter in and they are not ambulatory, and say the nurse is not the best nurse and they're not providing perineal care with every fundal massage, that Foley catheter is sitting in all of that blood that is being massaged out with the fundal examinations. So she's at a really high risk for developing a UTI, right? So for a postpartum C-section patient, we're extra worried about that. Mastitis for sure. We're worried about any time that there's a patient that states she's breastfeeding, and occasionally even patients that are not breastfeeding, we're going to worry about mastitis. Okay. So, what additional questions do we want to ask this patient to kind of find out, like, okay, what is causing this? What is causing this fever? What is causing this infection?
Where's the pain coming from?
Yes, definitely.
Is there any redness or swelling anywhere?
Mm-hmm. Yep.
Any bad odor associated?
Yep, for sure. Is she having any weird smelling like vaginal discharge? So let's see what we have. How long has she had her fever? Has she had any pain or burning during urination? Has she had any pelvic or abdominal pain? Any breast pain or tenderness? What does vaginal discharge look like? Does the discharge have an odor? Is there any redness or drainage at the incision site? So when we look at these questions, right? Like after you've worked in nursing or even after like studying this material, you're going to look at this and say like, okay, so we know if we ask a patient, has she had any pain or burning during urination? That's assessing whether or not she has a UTI, right? So just based off of these questions, you can kind of see or discern what this nurse is assessing for, right? Does she have any pelvic or abdominal pain? That would point us in the direction of endometriitis. Any breast pain or tenderness that's associated with mastitis. Any vaginal discharge and what does it look like? And then any redness or drainage at the incision site because we're assessing for the presence of a surgical site infection. Okay. So all these questions are going to give you a good idea. So like if you have a patient who's been postpartum and they call into the hospital because oftentimes you're triaging these kinds of patients over the phone, which poses its own set of complications, right? Because you're not actively able to see the incision or you're not able to see the mom's breasts and assess her physically. We need to ask them really thorough questions to kind of give us a good idea of what's going on with this patient. Okay. So what are some things that we would see what's concerning versus what isn't? So a fever over 100.4 postpartum day 2 through 10, we're going to worry about. Anything that occurs in the first 24 hours as far as a fever, we're not going to use that as a diagnostic tool. We're going to wait until about 2 to 10 days after postpartum to determine, okay, yeah, this is as a result of an inflammatory response that could be being triggered by an infection. If mom has a fever, she's lethargic, or her heart rate is high, that is something that is concerning. That would point us in the direction of an infection. So these things that you guys are going to need to know this information right here for your exam, okay? You need to be able to tell me if this is endometritis, mastitis, if the patient has a UTI, or if she has a surgical site infection, because each one of these things are going to present differently, right? So with endometriitis, we have foul smelling discharge, a tender abdomen, and then her uterine tone is going to be poor. She might have some involution. Her bleeding might pick up a little bit as well. With mastitis, she's going to have that unilateral breast tenderness and redness, warmth, pain with flu-like symptoms. And then with a UTI, she's going to have frequency, urgency, and burning. Finally, with the incisional site, she'll have a redness, swelling, tenderness, and some purulent discharge. So each of these types of infections that women can obtain postpartum have different telltale signs or symptoms that are associated with each one. Just to kind of get your guys' brains thinking, if a patient calls in who, let's say, she's had a 3rd-degree perineal laceration, okay, she's 3 days postpartum, and she calls in and says, I'm having burning when I pee. Should we automatically just assume she has a UTI and prescribe her antibiotics?
No,
Right, why not?
because it could be coming from the incision.
Yes, exactly. Yeah. So we need to be able to discern, like, okay, what is a normal symptom that you could experience postpartum versus when are we worrying about an infection? Okay. So with a patient who has had a 3rd or 4th-degree perineal laceration, they are going to have burning whenever they urinate, probably for the first week or so when they go home. Okay. So we cannot strictly use just burning as a diagnostic symptom to prescribe this patient antibiotics, right? But we also need to take all of these things very seriously because, like with any infection, what are we worried that any of this could eventually lead to? Like the big, bad, scary one.
Sepsis.
Yeah, sepsis. Anytime you have any kind of infection or immune or inflammatory response, we are worried that it's going to progress up until the patient is septic. Okay, that is very rare with these kind of postpartum infections, but not unheard of. Okay, so we need to educate our patients so that they know that this is serious. Okay, so what is our priority whenever we're talking about dealing with any type of like infection with a patient? What is our treatment plan? What should we do?
We should know a complete list of any drug allergies. That way, if we were to prescribe an antibiotic, we are making sure we're not prescribing one that she's allergic to.
Yeah, definitely. So you said it too, like we're going to want to get this patient on an antibiotic, right? Get these patients treatment, get them some medications. What else are we going to want to do for this patient? We're gonna have to educate them on our antibiotic regimen, right? So we're going to administer and teach the use of antibiotics. So like you mentioned, we need to make sure that these patients, we have a complete list of allergies. If they are allergic to certain antibiotics or not, we're obviously not going to prescribe those. We need to give them our good old-fashioned farm education as far as antibiotics. So how to take antibiotics. Don't stop it halfway through. Eat plenty of yogurt or probiotics while you're taking antibiotics to prevent yeast infection. Don't take them with other medications. Take them at the same time every day. That kind of stuff. Same with the use of analgesics for pain and fever. So if this patient's taking Tylenol around the clock for a fever, we need to be able to tell them, okay, if your fever persists within 24 to 48 hours, and even if you're not taking the Tylenol, you need to go into urgent care because we need to evaluate you closer. Okay. Same with pain medication. If their pain is unrelieved by pain medication, it's oftentimes because the disease process has progressed to something way worse. Okay, so this is something that we're going to need to teach our patients about. We're going to tell them to be frequently assessing their symptoms. If they are back in the hospital, we need to be frequently assessing their symptoms because, like I said, we do not want this to escalate or become worse because that can be a whole nother mess of problems for this patient. We also need to provide really, really good education, okay? So like, we need to be teaching them about maintaining cleanliness or personal hygiene. So if you have a patient, like I mentioned earlier, who had that 3rd or 4th degree perineal laceration, What are you going to want to tell this patient? How would you want to educate them?
Make sure to keep the area clean and dry.
Yes, for sure.
Maintain good hand hygiene.
Yep, definitely. What else about like a perineal laceration is important for this patient population?
I'm not sure the name of it, but that little squeeze bottle.
Yeah, the
The
peri
peri
bottle.
bottle.
Yes, exactly, the peri bottle. We also want to be teaching these patients too, like not to have sex or insert anything into the vagina until they are cleared by their physician. I mean, especially if they have any type of perineal tear, for sure. So we also need to think about it too, like things that may seem common sense to you or I for a patient may not be common sense. Okay. So, for example, I had a patient who had a third-degree perineal laceration. She came back into the hospital about 5 days after she was discharged from the floor, and she had one of the worst infections on her bottom that I've ever seen postpartum. Okay. We were asking her questions like, were you in a tub? Did you go swimming? Like, what happened? Well, this patient, it turns out, did not change her peri pad that she left the hospital in until she came back with that infection. Okay, so for us, we know every time you go to the bathroom, change your pad. Every time, every 2 hours, change your pad if you're not going to the bathroom. For patients that don't know this information, we still need to go over it with them, even if it seems like it might be common sense. This patient in this case, the reason that she did not change her peri pad wasn't because she didn't know to do that. It was because financially she could not afford to go and buy more pads at the store, and she didn't have anyone to watch her baby or stay home with her other kids when she went shopping. Okay? So that's the other thing we need to assess as a nurse. Do these patients have what they need at home to be successful to avoid this kind of infection, right? So we gave her a bunch of pads from the hospital. We just gave her a bunch of our packs of it so that she was set up for the rest of her postpartum period, okay? But these are the things we need to talk to our patients about. So, with mastitis, some things that we're going to educate our patient on. They are going to use warm compresses and frequently pump or breastfeed. That includes too on the infected side. Okay, your moms are going to be so upset when you tell them this, but they still need to pump and they still need to breastfeed on the affected side to draw out that infection. Okay, any of the stuff that is being discharged from the nipple is not going to hurt the baby. The baby can still breastfeed and it's okay. For lacerations, we kind of talked about this already, but we need to do proper perineal care, make sure the patient's using a peri bottle, and that they're changing their pad frequently. For surgical incision, keep it clean and dry, okay? These patients should not be sitting in tubs. They should not be swimming. They should not be going in hot tubs or bodies of water until they get clearance from their provider. So that's all stuff we need to educate them on. For a UTI, increase their fluids, and then proper perineal care, wiping front to back. Okay, so let's go over this. We're kind of changing gears here. We're going to be talking about some postpartum depression, baby blues. So we have Stephanie, and she's a 29-year-old primiparous. So what does primiparous mean?
First delivery.
Yeah, first delivery. Yep. First delivery over 20 weeks. So she had a baby girl named Emma. She comes in after several missed appointments. Emma's now 6 weeks old. Stephanie presents with symptoms including sleep disturbance, loss of appetite, and panic attacks. In addition to these symptoms, Stephanie complains about not having normal feelings towards Emma. She felt as though the baby is not hers and that she is a total stranger. Stephanie says she did not retain any of the prior good feelings she had when she was pregnant and felt that although she had bonded with the newborn in utero, those feelings were now gone. Stephanie's hair does not look like it has been washed or brushed in several days. She has dark circles around her eyes. She states that all she does is sleep or wants to do sleep. She tearfully states that she feels like she's a bad mom because she knows she should take care of Emma, but she just doesn't want to. Stephanie has a history of depression and she quit taking her sertraline whenever she became pregnant. Okay. What stands out to you guys here?
Several missed appointments,
Several missed appointments.
sleep disturbances, loss of appetite, panic attacks.
Yep.
She
Great.
don't have normal feelings towards her baby.
Yes, that's a big one. She does not feel normal towards her baby.
Timeline now that we're 6 weeks out from delivery.
Yes, that's excellent. Yes, 6 weeks. That's kind of a long time past out of postpartum to be feeling this way. Excellent. Yeah, you guys hit on all the big ones that we're worried about. So, with baby blues, right? Because we're going to break these things down into two: baby blues, postpartum depression, and postpartum psychosis. So, what do we see with baby blues? What's our normal?
Fear, anxiety about caring for a newborn.
Yeah, they can have a little bit of anxiety for sure. How long does this usually last?
A few days.
It can last up to like 2 weeks, 10 days postpartum. So not like super long. Right, you guys got the big ones. So baby blues are caused by our hormone fluctuations, right? Because once we deliver that placenta, our estrogen and progesterone levels are going to drastically decrease. Okay, your body is going to be going through all sorts of fluctuations to normalize um, the hormone levels that are taking place in the mom's body postpartum. So it is normal for moms to be very emotional, tearful, anxious, fatigued. The biggest thing with postpartum baby blues that are different than depression is that these moms with baby blues are still bonding with their babies. So that is the biggest difference. They are not completely just ignoring the baby. They are wanting to still have the baby close to them. They're still wanting to snuggle. They're still bonding. They're still trying to create that bond. Okay. Concerning would be our postpartum depression. Okay. This lasts longer than 2 weeks. So in Stephanie's case, if she's coming in 6 weeks after delivering her baby, since being home, this is going to be, we're worried more about postpartum depression than we are baby blues. This has gone on way too long, and this mom is probably going to need some counseling, assistance, medicine, whatever it may be. Okay. These moms with postpartum depression often report feeling detached from their baby. They have severe mood swings and they have thoughts of self harm. So, detachment from their baby would look like they don't want to take care of their infant, they're not interested in snuggling or holding the baby, they're not attaching, they're not bonding. That kind of stuff. This is way more concerning, right? Because we're worried about not only mom's safety, but also the safety of our baby, too. It evolves into postpartum psychosis, which can be very, very dangerous because the biggest thing that we see was like thoughts of suicide and harming and killing the baby. Okay. This is rapid onset, bizarre behavior, and oftentimes it's associated with hallucinations. Okay. So these three categories, baby blues, postpartum depression, and postpartum psychosis, you guys are going to need to know the differences in all of these for your exam, for sure. Okay. Any questions on these? Okay. With postpartum psychosis, it's most commonly like related to if a patient had a manic episode or like or were schizophrenic. It presents a lot like that. Okay. I've seen it before when I worked in the ER one night where a mom has like literally brought her baby into the ER and is like, someone needs to take this baby because I'm gonna like do something bad to them. Like they are aware. And that's more postpartum depression. Okay. If they're aware of how they're feeling and they're aware that they're having these thoughts, we're going to say that it's more closely linked to postpartum depression. Whereas postpartum psychosis, these moms are not really in a good state of mind. Okay. So, what is our priority? We need to make sure that safety is our number one priority all the time. So, we're going to support this mom and give her good education. Tell her what is normal versus what is not normal. If they're in the hospital, we're going to be frequently assessing to see if mom's getting better or she's worsening. We're going to coordinate some therapy and support groups, get mom some good access to community resources, and then teach her that she needs to seek help. If she gets prescribed medications, we're going to teach her. We're going to teach her how to use the medications, teach her what a good regimen is, and how to follow it, um, and then just continue to monitor her. Okay. All right. So that concludes the PowerPoint for week 4. I'm going to get week 5 set up, and then I'm going to run to the bathroom because I have to pee already. All right, guys, let's take 5, and I'm gonna run to the bathroom. I was planning on ending class a little early because we're not gonna take our full 15-minute break. So I'm planning for us to end around 8 p.m. tonight, but I'm gonna just run to the restroom. So just give me like a couple minutes, okay? All right, thanks everybody. If you want to come back on screen, we'll get started on week 5. Okay, so this week we were focusing on high-risk perinatal care. First, we're going to review from last week a little bit again. What are 3 things that a nurse can do to manage uterine atony? So first, somebody tell me what uterine atony is.
Isn't it like failure of the uterine muscles to like contract?
Yep, exactly. So it means that our uterus has poor tone. Okay, so whenever we have a uterus that has poor tone, we're at a high risk for a postpartum hemorrhage. So, what are 3 things that a nurse can do to manage uterine atony?
Massage the fundus.
Yep, massage our fundus. What else do you guys remember?
Medications.
Yes, specifically which ones? Do you remember the ones that we talked about?
Oxytocin, Methergin, that one.
Methadone. Yep, uh-huh. Exactly. We have 2 more that we talked about.
Misoprostol,
Yep, misoprostol or Cytotec. And then what's the last one?
ergometrin.
Is that, I forget the name, but it should be Hemabate. Is that the other name for Hemabate? I'm like, I
Yeah,
can't remember what it is. I'm always just so used to saying Hemabate. Yeah, you got it. You're
Yeah.
fancy. So when we're talking about those meds, so we have oxytocin, misoprostol, Hemabate, and Methergin. What do we need to know about Methergin? Who can't have Methergin?
Patients with preeclampsia.
Or high blood pressure.
Yeah, patients that have high blood pressure for sure cannot have Methergin. What about Hemabate? Who should not have Hemabate?
If a patient has asthma.
Yep, if a patient has asthma. Great job. So we're going to massage your fundus. We're going to give our medications. What else? What's another one that we kind of talked about last week?
Encourage urination.
Yeah, we're going to have her pee. Great. If she can't, then we're going to have to straight catheter or put in a Foley. So we're going to massage our fundus, manage our bladder, and then medications. Okay. When we talk about managing our bladder, why is that important? Like, why are we worried about a patient's bladder getting too full? Besides, like what does it do from like an anatomy standpoint? If
It
we,
displaces the uterus.
yeah, that's when you're going to see that uterus shifted off to one side or the other. Okay. Because your bladder is full, it's filling up. It's not going to allow that uterus that's trying to contract down to its pre-pregnancy size to fully contract and harden. So that uterus is not only going to displace the fundus, but it's going to cause the fundus to be boggy, soft, and it's going to increase mom's bleeding. Okay. So we already talked about our meds: Pit, Methergin, Cytotec, and Hemabate. What are 3 signs of hypovolemia if we have excessive bleeding? What can we see? How does our mom present?
Tacky.
Yeah, her heart rate's gonna be high.
Low blood pressure.
Lightheadedness.
Lightheadedness and low blood pressure. Yep. What's her skin gonna look like?
Pale.
She's gonna be pale. So anytime you see hypovolemia, these are the signs and symptoms that we associate with that. So tachycardia, hypotension, oliguria, so she's not really peeing very much. Pale, cool, and clammy skin, dizziness, and confusion. Okay. If the client shows signs of hypovolemia, but her fundus is firm, what other possible causes should the nurse assess for?
Incisional bleeding?
Yeah, from a perineal laceration. Excellent. Yeah, that's exactly what we're going to look for. The other one is we're going to assess for a hematoma. Okay. So a hematoma and an unrepaired perineal laceration can cause bleeding. If your fundus, and if you're doing a fundal massage and her fundus is it's midline, it's firm, it's at the umbilicus, and we're still having like unknown sources of bleeding, that should be a red flag for you to assess her perineum more closely for either the presence of a hematoma or for an unrepaired perineal laceration. What education should the nurse provide for a new mom who's concerned about how to identify postpartum depression?
Monitor for feelings of like you don't like lack of bonding. You
Yeah,
know,
yeah, definitely. Lack of bonding, that's a good one. So we're going to tell them to contact the clinic if symptoms are worsening, if they last longer than 2 weeks, because postpartum baby blues period, it should only last them about that 2 week period. If they feel themselves like detaching from their baby or if they have thoughts of self-harm. Okay. What education would be helpful for a mom who's diagnosed with mastitis?
Warm compress, pump as much as possible, let the baby nurse.
Yeah, excellent. Heat before feeding to help the breast empty. Wear supportive bra. Feed on the non-infected side first, if painful. Oral analgesics and then antibiotics. Okay, so all these things we're going to be giving or doing for mastitis. Okay, anyone have questions over review from week 4? Awesome. Okay, so moving on. Something that we talk about a lot in week 5 is hyperemesis gravidarum versus normal nausea and vomiting during pregnancy. Okay, so we're going to go through each one of these little things and identify if it is belonging to hyperemesis gravidarum or just is it normal nausea and vomiting. So before we get started, who can tell me a little bit about hyperemesis gravidarum? Like, what is it?
Is it out like when they're vomiting nonstop?
It's basically very, very, very severe nausea and vomiting. But like not in a like with the normal nausea and vomiting in pregnancy, like women will just like occasionally throw up, they'll get nauseous, whatever. But it typically will go away and they will most likely be able to eat or drink food still throughout the day. Hyperemesis gravidarum patients, these patients throw up all the time. They could be on an empty stomach. They can be in the middle of the day, at night, in the morning. It doesn't matter. These patients are at a risk for severe electrolyte imbalance and severe dehydration. So it's basically nausea and vomiting, just like very intense. Okay. So let's go through each of these and kind of match it up to whether or not it's hyperemesis gravidarum. So vomiting that causes severe dehydration. Would that be?
Hyperemesis.
Yep, that's hyperemesis. What about ketonuria?
hyperemesis.
Yep, it causes electrolyte imbalances.
Nausea, vomiting.
So I'm going to put this with a hyperemesis because even with nausea and vomiting, they most of the time can still keep down fluids and electrolytes. With hyperemesis, they're getting sick so frequently that we're worried about electrolyte imbalance. Vomiting that allows you to keep some foods down.
Normal.
Yeah, that's normal. Causes nutritional deficiencies.
Hyperemesis.
Hyperemesis.
Hyperemesis. Nausea sometimes with vomiting.
Normal.
Normal. Nausea with severe vomiting.
Hyperemesis.
Hyperemesis. Persistent vomiting that causes weight loss.
Hyperemesis.
And vomiting that does not cause severe hydration.
Normal.
Yep. So the things that can be in common for both of these would be a distaste for certain foods, food odor can trigger it, and then nauseous at any parts or times of the day. Okay. So for your exam, you guys are going to definitely need to know the difference between hyperemesis and then just normal nausea and vomiting. The biggest thing with hyperemesis is that it's to the point that we're worried about severe dehydration and electrolyte imbalance. Okay. What would we anticipate the treatment plan and education be for a patient with hyperemesis?
Avoiding an empty stomach.
Avoiding an empty stomach.
So dry, bland, high protein, small meals.
Yep, definitely.
Medications like Zofran.
Yep, excellent. There's a lot of education for this. A lot of things that we can tell our patients.
Alternate between fluids and solids.
Uh-huh. Yep. So let's see what we have so far. So we're going to eat that dry, starchy, easily digested carbs on waking and when nausea occurs. The small, frequent meals. Avoid fried, acidic, or fatty foods. They can wear a motion sickness wristband. Give them some anti-nausea medication, so Zofran typically. Herbal tea or ginger tea. Ginger is really awesome for nausea in pregnancy. So ginger tea is perfectly safe. Women can drink that. Sometimes if it's like organic forms of ginger ale, that can also help. So recommending these things to the mom is going to just benefit her. Avoid sudden movements. So telling her to change positions slowly, getting up out of bed very slowly. We want to avoid upsetting her stomach. Have her suck on a popsicle if she's vomiting on an empty stomach. So if she's continuously getting sick and she hasn't had anything to eat, we want her to at least like try and suck on a popsicle to get something. Cold foods are better tolerated whenever patients are feeling nauseous. Alternate food and fluids. Remain upright after meals. And then if it's to the point that she's not able to keep anything down, we're going to have her come in and get an IV. The other thing that's important with these patients is we need to be telling them to monitor their intake and output very closely, right? So if a mom gets to the end of the day and she's like, all I've had to eat has been half of a saltine cracker. I had maybe a Gatorade, and I've thrown up 25 times. This patient probably needs to come to the hospital so that we can assess her baby, make sure baby's doing okay, and also hook her up to an IV to give her IV nutrition or IV fluid. Okay, so we need to educate patients on how much is too much to be throwing up and when is it to the point that we need to intervene and administer medication. Okay, so we're going to start talking now about all of our blood pressure issues. We're going to talk about preeclampsia and all the things associated with that, okay? So the next couple things that we're going to identify are not necessarily either hypertension or preeclampsia. They're going to be those parameters and the definitions of either hypertension, chronic hypertension, gestational hypertension, or severe hypertension. Okay, so let's see if you guys remember the terminology and the definitions of each. So if your patient has a systolic blood pressure greater than 140 or greater than 90, what would we classify this as?
Preeclampsia.
So this would not be preeclampsia yet. This is going to just be our hypertension. This is our guidelines for determining that mom's blood pressure is high. Okay, we need to have it on two separate measurements. If a patient's blood pressure is greater than 160 or 110 based on two separate measurements, what would this be classified as?
Preeclampsia.
Preeclampsia?
So this is not preeclampsia yet either. So your preeclampsia is not this, none of these is going to be preeclampsia. These are just your blood pressure, like, terminology, like how we define it in the on the floor, like when you're diagnosing a patient. So this is going to be your severe hypertension, your severe range blood pressures. Okay. For preeclampsia, we need to have not only a high blood pressure, we need to have other signs and symptoms or other lab values that are abnormal to diagnose them with preeclampsia. Okay. So if you have a patient who's developed hypertension at or after 20 weeks gestation, so she has not had high blood pressures before she was pregnant, what would this be classified as?
Is that one preeclampsia now?
No, this is gestational hypertension. I think it's misleading because the title says hypertension to preeclampsia, where all of these are just the definitions for what we would call high blood pressures. So if there's hypertension that's present before pregnancy and or appears prior to 20 weeks gestation, that's chronic hypertension. Okay? So for your exam, for the purposes of your test, you guys should be able to say whether a patient is having severe hypertension, if she's a gestational hypertensive patient, or if it's just hypertension. So you need to know these parameters because these are going to help you diagnose a patient whether or not they are preeclamptic or like what their blood pressure is doing. Okay? So this is really just definition right here. Okay. So we have a scenario that we're going to work through. A 38-year-old female is 36 weeks pregnant. She arrives to labor and delivery for a headache that won't go away with acetaminophen. The patient also states, I keep seeing floaters and have even thrown up from it. I do have some swelling and my upper abdomen has really been hurting. My head is really hurting. The nurse notes that the patient's blood pressure is 156/98. What are we worried about here? What stands out to you?
Headache that's not relieved with Tylenol.
Yes.
Floaters, so vision changes.
Visual disturbances? Uh-huh.
The elevated blood pressure.
Yep, definitely her high blood pressure.
Her upper abdomen hurting.
Yes, her upper abdomen pain, for sure. Yeah, all of those things should be a red flag for you. Like, oh, this lady is kind of showing us some signs and symptoms that she might be preeclamptic here. Okay. So, you guys kind of already talked about what we would be concerned about versus what would not be concerning. So, here is our criteria for diagnosing preeclampsia. We have to have a blood pressure greater than 140/90, at least 2 more than 4 hours apart, plus another symptom. Okay? So preeclampsia is not just diagnosed whenever a patient has a blood pressure. Okay? They also have to have one of these following symptoms. Protein in their urine. Okay? They're going to have an elevated PC ratio, protein creatinine ratio. Do you guys remember the number that is concerning for PC ratio? If a patient's PC ratio is 0.3 or higher, that is going to indicate that she is preeclamptic. Okay, that is an elevated protein creatinine ratio. Elevated liver function tests, so their AST and ALT enzymes are going to be high. They're going to have some swelling, especially in their face. They're going to see like facial swelling on their feet, their extremities, they're going to be swollen. They're going to have some renal insufficiency and oliguria. So they are not going to be having too much urine output. And any of the urine output that they put out is going to be very concentrated and just like not healthy. They'll have some thrombocytopenia, so they're going to have very low platelet counts. They'll have those visual changes, so the blurry vision, seeing floaters. Their headaches are not going to be relieved with Tylenol. And then they're going to have that right upper quadrant or epigastric pain. Okay, So all of these things listed here are signs and symptoms of preeclampsia that you guys will need to know for your test. Okay? But like we said on this criteria, they have to have these along with an elevated blood pressure for them to get the diagnosis of preeclampsia. Okay? Does that make sense? And then what do we define as eclampsia?
A seizure.
Yes, if a patient has a seizure, then she's eclamptic. Okay? That's the difference. Preeclampsia, their blood pressures are high, they have these other symptoms. An eclamptic patient has a seizure. These patients are also going to be hyperreflexive, so they're going to have 3 plus and 4 plus deep tendon reflexes, and or clonus is going to be present with these patients. Okay? So let's go through these 4 things, okay? So you have a patient who comes in. Let's just say you have that same patient that we were just working on. Her blood pressure is 156 over whatever, 98. What is going to be your priority intervention with this patient? She just walked into the L&D unit, okay? Straight off the streets, no IV, no nothing.
Monitoring.
Yep, we're going to put baby on the monitor.
Safety.
Prioritize our safety. So what would that include?
If they're going to have a seizure, so padded bed rails. Uh,
Yep, padded bed rails. What else would we want to have at the bedside?
Suction.
Yep, suction and oxygen. This patient just came off the streets and her blood pressure is super elevated. What else do we need? How are we going to manage her blood pressure?
Would it be fluids?
Right. So what are we going to need to give her fluids?
An IV?
Yeah, we need an IV, probably 2, if you see that her blood pressures are this high. So we have monitoring, we have initiating seizure precautions. We're going to give her some IV fluids. What medications can we give to lower her blood pressure emergently?
Magnesium.
So magnesium is mostly what we're giving to make sure she doesn't have a seizure. It can help with blood pressure, but there's 3 other medications that we can give to moms to drastically emergently lower her blood pressure. What are they?
Labetalol,
Labetalol. Yep. Is that IV push or is that what? How do you give that one?
IV,
Yep. What's the other 2?
hydralazine,
Yep. Hydralazine. You got it. And then if you can't get an IV, like this patient, her veins suck, you've tried multiple times, you have an anesthesia provider coming in to help you, what can you give her in the meantime to help lower her blood pressure?
I don't want to say it wrong, but I think it's nifedipine.
Yeah, nifedipine, you got it. Listen, you're doing great. Yeah. So your 2 medications that you give IV push to manage hypertension to lower the blood pressure emergently would be your IV push labetalol, your IV push hydralazine. If you do not have an IV and you need to administer medication really quickly, you can give them an oral dose of nifedipine. Obviously, it's not going to work as quickly as the other 2, but it's something to help bring that blood pressure down as you're trying to get her IV started and as you're trying to do all these other things that you have to do. Okay? So that would be how we manage our hypertension. You mentioned, Miranda, giving magnesium. So that is what we're going to give to prevent a seizure. What are some things that we need to know about magnesium? Like, you're the nurse, you're the bedside nurse, you're going to be administering it. What are some things that we need to know about the patient, or what do we need to do?
Monitor them
Yes. Specifically, like how often?
every hour.
So when we're doing magnesium, do you guys remember how it's given typically?
Ain't it in a bolus?
Yeah, so you're giving an IV bolus. So the initial administration of magnesium is given in an IV bolus, and the bolus is typically 4 grams to 6 grams in 20 minutes. So when you're giving that bolus, what are some things that you need or you need to know as the nurse? So for this period of time, we're going to be monitoring them. How often should we be getting their vital signs and performing a focused assessment?
Every 15 minutes.
So it's actually every 5 minutes for a bolus. Okay. And here's why. Magnesium is it's a high alert medication. Okay. You need to have 2 nurses at the bedside whenever you're initiating this medication. You're monitoring your patient every 5 minutes. What are some signs and symptoms of magnesium toxicity? And I'm not just talking about like normal symptoms associated with magnesium. Like, this is the stuff that we need to shut our magnesium off right now because this is emergency. How would your patient look? What would they do?
Would they get kind of floppy?
So they're
Like,
going to have absent deep tendon reflexes, yeah. So magnesium is a central nervous system depressant, okay? So its job is to relax the central nervous system. It's to relax the body. So how would your vitals look? How could this patient potentially present?
Hypotension.
Everything's going to be lower. So
Respiratory depression.
yes, exactly.
Lethargic.
These patients, if they have a magnesium toxicity, they're going to have absent deep tendon reflexes. They're going to pass out on you or be hard to wake up. They're going to be super lethargic. They're not going to have any urine output, hardly at all. Respiratory depression is a really big one. So their respiratory rate is going to decrease dramatically. So these are all things that we need to look for with magnesium toxicity. If a patient has magnesium toxicity, what are you going to do? What are your interventions?
Stop it.
Yeah, you're going to shut your mag off. Number 1. What else?
Do we give calcium gluconate?
Yes, excellent. Yeah. The reversal for magnesium is calcium gluconate. So anytime you're administering this medication, it needs to be at the bedside with you so that you can administer that emergently. Okay. So your mom, you're at the bedside, you're giving magnesium, you had your other nurse that came in with you. We are starting your bolus. Your mom shows signs of magnesium toxicity. What do we think is happening to our baby?
Sedation.
So your baby's going to feel this too, for sure. So your mom's blood pressure, she becomes extremely hypotensive. Her respiratory rate decreases. Your baby is most likely going to have a prolonged deceleration or some type of deceleration, some way, shape, or form. Okay. So what are our interventions for intrauterine resuscitation for our fetus? What are the things that we do if baby is having a decel?
Turn
Change
her all
positions.
Yep, change her position. So we're going to put her on that left side, laying down. What else?
Oxygen.
Oxygen. Yep. Fluid bolus. Right? So if your mom has lost consciousness, do you think it's also going to help mom to lay her down flat on her left side and start an IV fluid bolus and give her oxygen? Yes. Okay. So in this case, the things that we're doing to resuscitate baby are the things that we're going to need to do to help resuscitate mom. Okay. If she's having if she's having magnesium toxicity, obviously we're giving her calcium gluconate. We're calling a rapid response, and then we're doing all these other interventions that we would do for intrauterine resuscitation for the baby. Okay. So, like we said, MAG is a CNS depressant. Signs and symptoms of toxicity are those absent deep tendon reflexes, urine output less than 30 mLs, respiratory depression, slurred speech, and severe muscle weakness. Normal things that you can see with a patient who has magnesium running that are not necessarily toxicity and they're just normal side effects is your patient is going to tell you that they feel like absolute crap. This medication makes patients feel disgusting. Like they don't like it. They say that they feel really heavy, they feel hot, they feel warm. Some patients that I've had before have thrown up, they get nauseous. So obviously if they're dizzy, they're going to be a fall risk. So we need to be careful if they're getting up to use the restroom. If they're so dizzy and sick to the point that they cannot get up on their own, then we need to help and just put a Foley catheter in and implement bed rest. So those are things that you can see with magnesium that are not necessarily okay, let's go ahead and just stop it, right? Because these patients need this medication too. So these are things to be aware of. So when you're administering that first initial bolus, and you have to do a focused assessment every 5 minutes to assess for magnesium toxicity, what are you assessing based on how a patient can present with toxicity?
Respiratory rate.
Yep, respiratory rate.
Muscle reflexes or strength.
Yep, we're going to assess their strength, assess their deep tendon reflexes, assess for any clonus or absence of clonus.
Urine output.
Urine output, definitely. We're going to assess their mental status, right? Going to keep talking to them and asking them questions. So one of the things that we always assess whenever we administer magnesium is we listen to their lung sounds. Can someone tell me why we need to listen to this patient's lung sounds? Not just to assess respiratory rate. So think about it. They're swelling, right? They have extreme edema if they're having if they're preeclamptic. So these patients are in a fluid volume overload. Okay. So if we're thinking about it, these patients are holding on to all their fluid. They're not having any urine output. They're having renal insufficiency. They have edema. They have localized and generalized swelling. Are we worried about that fluid settling in their lungs? Yeah, for
Yeah,
sure.
you wanna listen for like crackles, rails.
Yes, exactly. Yep. So we're listening for lung sounds or abnormal lung sounds that can indicate that these patients are developing pleural effusions, that they're putting on way too much fluid on their lungs. So we're listening to that as well. Okay. So if you know that your patients are in a fluid volume overload, what else are we going to implement?
A diuretic.
Diuretics.
So not necessarily diuretics. The magnesium should and the magnesium and the medications you're giving for her blood pressure should ultimately correct that and help her diurese. Would this patient be on a restriction, a fluid restriction?
Yeah, a fluid restriction.
Yes.
Yes, we're going to have this patient on a very strict INOs. We're going to have her also on a fluid restriction because we want to prevent any excessive amounts of fluid volume overload. So these patients typically are given only maybe 125 mLs an hour via IV, and then an oral intake is up to the provider. Okay. But you need to be doing eyes and nose on your patient every hour. So you need to be counting what's in the Foley, what's in the hat in the toilet, what they're drinking, because it's very important to be able to see how much fluid they're taking in versus what they're putting out. Okay. So we talked about how our antidote is going to be calcium gluconate and that we need to turn off our magnesium if they're showing signs and symptoms of toxicity. These patients are also at an increased risk of uterine atony. Why do you think? is that magnesium ultimately going to relax the uterus as well as all the other muscles? Like we're talking about assessing deep tendon reflexes, right? So your magnesium, excuse me, is going to decrease the contractility of your uterus because it is completely relaxing and depressing your entire central nervous system. Okay. So if you have a patient who's been on magnesium throughout her entire labor for the last, let's say, 24 hours, she's delivered, is that uterus going to be as firm as somebody who was not receiving magnesium? Definitely not. Okay. So patients who receive magnesium during labor are at an increased risk for a postpartum hemorrhage following delivery. Okay. So we need to have our uterotonics available at the bedside. Magnesium is a medication that patients are going to stay on in the postpartum period for up to 48 hours after they've delivered because we're still trying to prevent seizures. We're still trying to maintain mom's neurological function and neurological status. So we're not going to just abruptly stop this medication. Okay. So we need to be continuously massaging their fundus. If a patient is on magnesium sulfate during labor, this is a 1-to-1 very high risk patient, okay? Because we just went through all the things that can happen with this patient. This is not somebody that you're going to be like, oh yeah, I have this patient on mag and I also have 3 other labors going on. This is your only patient that you are taking care of, okay? This is kind of going into week 6 content. If you guys know this, you get a gold star. What other reason would we potentially give a mom magnesium sulfate? And it doesn't necessarily have anything to do with the mom.
If the baby's in distress, would this calm down their like overstressed system? Like if their heart rate's super high?
So that's a really good train of thought. It does have something to do with the baby, but not specifically what you just said. But it does have something to do with our fetus. So sometimes we can see magnesium being administered to moms who are going into preterm labor. And this is specifically for neuroprotection of the newborn. Okay. Magnesium is going to help with the neurological development in our infant and prevent the baby from developing things like cerebral palsy. Okay. So magnesium is a huge neuroprotector for our unborn baby. Okay, which is pretty cool. We talk about that more when we get to week 6 content and then a little bit more whenever we get into talking about our newborn assessment. Okay. We already talked about managing hypertension. We have our 3 medications here. You guys need to know that labetalol and hydralazine can be administered IV push and Procardia is an oral med. Our monitoring. So obviously we're going to be continually assessing our mom for any preeclampsia symptoms. Signs of mag toxicity, we're continuously monitoring our baby and we may need to implement those measures for intrauterine resuscitation, our vital signs, and then the uterus postpartum if she's been getting mag. So we talked a little bit about how moms are in a state of a fluid volume overload, right? So is this a patient that you're going to really be wanting to give IV fluid boluses to all the time? No. So typically, if we see that this baby is not doing well on our monitor and we're continuously having to do resuscitative measures, this patient may end up getting a C-section sooner than later, right? Because we don't want to put mom at risk for a pleural effusion or any other type of symptom from her fluid volume overload. We're not trying to make mom hemodynamically unstable, okay? What becomes a little bit tricky whenever we're talking about magnesium and running labors is, do we deliver the baby if we're earlier than 34 weeks or do we not? Okay. And in these situations, we need to weigh our risk versus benefit for not only the mom, but for the baby as well. Okay. So if you have a mom who comes in who's 32 weeks, she's severe preeclamptic, she has to be on magnesium, but she's not in labor and the baby is tolerating everything fine, then we're going to keep her on bed rest. We're going to keep her in the hospital on long-term magnesium sulfate, and we're going to monitor her and make sure that she's doing well until she gets to the point that we can take the baby safely. Okay. If a mom comes in and is 34 weeks, and is severe, it has severe features and has severe blood pressures, we're going to prepare this mom for delivery of the infant. Okay? Because, like we said, preeclampsia is caused by the placenta, right? So, oftentimes, delivery of the placenta is going to correct preeclampsia. Okay? So, if we're going to prepare for delivery, what is betamethasone and why do we need to give it if this baby is early?
It's a steroid, and isn't it for their lungs?
Yeah, it's a steroid that improves fetal lung development. So it speeds up fetal lung development. Okay, so this is a medication. It's also called Celestone. This is a medication that we give moms. It's an IM injection. So they would get 2 injections 24 hours apart. And it basically hyper speeds up the baby's lung development, helps them develop that surfactant faster, so that they have less of a chance of having severe respiratory depression whenever they're born, or severe respiratory distress whenever they're born. Okay. How do we know that magnesium and all of our interventions and all of this stuff that we just did to help out this mom worked? She's not going to have a seizure. Her blood pressure is going to improve. She's going to start diuresing. She's going to have decreased edema as a result, and then her labs are going to improve. We're going to see a correction in all of these things, okay? So typically we're managing her hypertension with these medications and also administering mag sulfate to prevent seizures. Any questions on that? That covers a lot of the information that we need you to know for preeclampsia and hypertension in pregnancy. Okay. All right. So you have a 40-year-old woman. She's 34 weeks gestation, and she has the following vital sign reading. So at 10 o'clock in the morning, she had a blood pressure of 148/94 with a pulse of 88. At 2:30, she had a blood pressure of 150/92 and a pulse of 86. What should we assess for next?
Any additional signs of preeclampsia?
Yeah. We're assessing for like any protein in her urine. What are her reflexes doing? She have a headache? She having visual disturbances? She having that right upper quadrant or epigastric pain? Are her liver function tests elevated? Is her AST and ALT elevated? Are her platelets low? She have clonus or not? And then we also need to assess our baby, okay? Because like we said, we cannot diagnose preeclampsia without any of these severe features. Okay, we are going to move on now. We're going to start talking about gestational diabetes. Okay, kind of flipping around here. We're covering all the big things. So, for gestational diabetes, our scenario includes Nadia, and she is a 34-year-old of Indian ethnic origin who is now 24 weeks into her second pregnancy, her last pregnancy being 7 years ago. Nadia's BMI is 32.4, and her father has type 2 diabetes. GDM was diagnosed during her first pregnancy, and her first baby was born at term weighing 3.8 kilograms. She has been diagnosed with gestational diabetes during this pregnancy by a 3-hour glucose tolerance test. Okay, so what did we see, or what is concerning, what is not? Okay, so with poor glycemic control in a patient, what can this poor glycemic control prior to pregnancy and in the first trimester, what can this cause if a mom's blood sugar is not well regulated? What do we sometimes see with our gestational diabetic patients?
In the baby?
In baby and mom, both.
I was just thinking like a large baby at birth, but
Yeah.
you're thinking before that.
Yeah, a macrosomic baby. So like, yeah, that can even before pregnancy, that can affect like how big of a baby you're gonna have. If your blood sugar is not very well managed and not controlled, early in your pregnancy or even before your pregnancy, you still have the high risk of having a big baby. Okay. So other things too can be like congenital abnormalities. Moms are at a higher risk for a stillbirth, neural tube defects, and then prematurity in a patient who has gestational diabetes or even just diabetes going into a pregnancy. Would this be a concern for Nadia? Or were you worried about these things for this patient that we talked about? If we see her history, she had gestational diabetes in the past. She has a family history of it. She's now currently diagnosed with gestational diabetes. So yes, these are things that we're worried about for Nadia. So this one is kind of where you answered correctly, Christina. So she's had poor glycemic control throughout pregnancy. So what can it cause? One of the things is macrosomia. So a big baby. If you have a big baby, what else are we worried about?
The baby's blood sugar?
The baby's blood sugar. Yeah. Is baby's blood sugar going to be uncontrolled whenever they're born? Typically, yes. What else are we worried about?
Difficult birth.
Yes, specifically with a big baby, and this is kind of going to next week. With a big baby, what do we worry about as far as difficulties in labor or delivery?
Shoulder dystocia?
Yeah, shoulder dystocia, for sure. So that is what happens when that anterior shoulder gets stuck underneath the mom's pubic bone, and we have to try and release it during delivery. Okay, this is really dangerous because while we're trying to correct a shoulder dystocia, that baby does not have access to oxygen. So we're deoxygenating our baby. Our baby's not getting good oxygen intake. They're going to become hypoxic, leading to metabolic acidemia. So we're going to have to resuscitate that infant if that shoulder dystocia lasts for a long time. What other things can we see with the shoulder dystocia as far as like an abnormal assessment on the infant? We oftentimes see babies with severe clavicle fractures. Okay, that is the biggest thing that we'll see with a shoulder dystocia is baby will have had a fractured clavicle. Another thing that we can sometimes encounter is a brachial plexus injury, which is just like the strain of this nerve here, that can cause some lasting effects and some difficulties for the infant as they're growing. Let's see what else. So we talked about our risks with macrosomia. We're worried about neonatal hypoglycemia, so that baby's blood sugar not being very well managed, respiratory distress syndrome, and then an increased risk for preeclampsia. This is for mom. If they have a diagnosis of gestational diabetes, they have an increased risk for preeclampsia, ketoacidosis, infection, and hydramnios. When we talk about the amniotic fluid, we talked about this a little bit last week, I think. With a mom who's gestational diabetic, what are we worried about with her fluid? Are we worried about her having too much or too little?
Too much.
Too much. Moms with gestational diabetes are often predisposed to having polyhydramnios, okay, which is a risk factor in pregnancy all on its own. So we also need to educate our mom on signs and symptoms of DKA, because if she has diabetes, we need to be educating her on things that could indicate that her blood sugar is at a too high level. So that fruity breath, thirst, increased urination, abdominal pain, headache, dry and flushed skin, weak and rapid pulse, lethargy and drowsiness, and then a blood sugar that's greater than 200. Those are all things that we're going to worry about or tell mom to pay attention to, so that if she feels any of these things, she can go to the emergency department. Okay. So, what are some things that we're going to teach our patient on how to maintain their glycemic control? So, what are things that we're going to tell moms to do to help manage their blood sugar?
Avoid carbs.
Avoid fatty carbs, avoid unhealthy carbohydrates, yeah. Fatty foods, takeout.
Check their glucose readings often.
Yep, monitor their blood sugars frequently.
Exercise.
Yeah, what are the things like what do we typically tell moms that are pregnant how they can exercise? Or what kind of exercise should they be doing or how much of it, I guess.
Like low impact exercises?
Yeah, low impact exercises, things that aren't going to be super hard on their body. We typically also tell moms that they should be exercising about every for 30 to 60 minutes every day during pregnancy, okay? Is a good ballpark, good goal for them. So we're going to tell them to do their daily glucose checks, encourage them to exercise, reinforce a healthy diet. And then if they're taking any medications, or if they are prescribed insulin, we're going to need to educate them on how to do the insulin and when to administer the insulin. Okay. Typically in pregnancy, if a mom is diagnosed as a gestational diabetic, excuse me, one of the medications that we're going to recommend them to take is metformin. Metformin is a medication that we prescribe very frequently in pregnancy to counteract gestational diabetes. So we need to educate them on what are common signs and common symptoms from this medication. When should you be taking it? Should you be taking it on an empty stomach with food? Yada yada. We need to give them a really good education about the meds that they're taking. Okay. So with a gestational diabetic or even a pre-pregnancy diabetic, their insulin requirements are going to change during their pregnancy. Do you guys remember how the insulin requirements change during their pregnancy?
They're gonna be less sensitive to the insulin the further along in their pregnancy, so they'll have to take more.
Correct. Uh-huh. So in your first trimester, your insulin requirement is not nearly as high as it's going to be in the second and third. So your insulin requirement is going to decrease drastically in that first trimester. So they're going to not need to take as much insulin. Okay. And then it's going to increase in the second and third trimester due to insulin resistance. So they're going to need to have more insulin in the second and third trimester. And then once mom has delivered in the immediate postpartum period, that is going to decrease very, very quickly. Okay. So we need to know for our exam the insulin requirements and at which stage of the trimester, which stage of pregnancy those requirements change. Okay. So we're also going to be needing to monitor our fetal status. So with a gestational diabetic or even just like a type 1 or type 2 diabetic that was diagnosed pre-pregnancy, these patients are going to get NSTs more frequently than just a standard non-high risk patient. So they're going to have the fetal monitoring non-stress tests more frequently. They're also going to have ultrasounds measuring not only fetal growth and development, but also their amniotic fluid index. So they're going to be measuring the amount of amniotic fluid that the mom has. And then we need to really educate these moms on daily kick counts, okay? Because we just talked about how gestational diabetics have an increased risk for stillbirth. So we need to tell these moms if you feel any change in your fetal movement, any decrease in fetal movement throughout the day, you need to come into the hospital to get a non-stress test. Okay. And like we mentioned, these patients typically will deliver really big babies. So we need to prepare for a difficult delivery, which would be a shoulder dystocia or a cesarean section, depending on how that baby is doing and how mom is progressing in her labor. Okay. Last thing, we're monitoring our baby. We're watching for signs and symptoms of hypoglycemia. When we get to the point in class where we're talking about like neonatal assessment, we're going to talk a lot about signs and symptoms of hypoglycemia in a baby. We're not going to talk about that today. But we need to monitor for hypoglycemia, respiratory distress syndrome, and those birth injuries that we talked about because of a shoulder dystocia or because of like malpresentation or something that happened during labor. Any questions about this? You guys are doing awesome. We're covering a lot of stuff today, so stay with me here. All right. So we have a question. A woman who is 22 weeks of gestation had a C-section for both of her previous pregnancies. The woman experiences bright red, painless vaginal bleeding. On her arrival at the hospital, what condition should be assumed unless we rule it out? What do you guys think?
D.
Preeclampsia.
D.
So it's not A or B.
Placenta
It's
previa.
D.
Yep, but placenta previa. How can we determine that a patient is having a placenta? Okay, so first let's back up. What's a placenta previa? Somebody tell me that.
When the placenta is partially or totally covering the mother's cervix.
Yeah, The placenta, as you can see in this picture here, it has grown over that mom's cervical opening. Okay. Why is this an emergency or why is this not good?
She's not going to be able to deliver the baby vaginally
Correct. And why not?
because the baby's head can't engage down into the canal.
That and also if that is the presenting part, so we always talk about presenting part. In this case, your presenting part is your placenta. Can you deliver a placenta before you deliver a baby? No. So that is why we're worried about placenta previas, because this placenta has grown over the cervical opening. So if this mom starts to make cervical change, she's dilating, she's effacing, this placenta is going to be delivered first. And that's an emergency, right? Because the placenta is the baby's source of oxygen and nutrition. So without that placenta, that baby's not getting oxygenated and that baby's going to die. So we need to make sure that we're delivering this patient via C-section. Typically, if a mom has a diagnosis of a placenta previa, we do her C-section when she's 37 weeks. And that is to make sure she does not go into labor because it's very high risk. And these can happen very quickly. When mom starts to go into labor and there's a placenta previa and the placenta is in front of the baby, we need to get that baby out immediately because that placenta's already started to come off of the endometrial layer, which would be a placental abruption, right? So this is an emergency. If you have a patient that comes in and you know she has a placenta previa or you suspect that she has a placenta previa, what are you not going to do?
Vaginal exam.
Yes, you're not going to perform a vaginal exam. Why would you not want to perform a vaginal exam?
You can rupture the placenta.
Yeah, you can cause a placental abruption. You can cause a placental you can cause damage really to the placenta if you're performing a vaginal exam. Okay, so those want to be avoided. How else are we going to determine if this is a true placenta previa? What do we need to get?
A C-section?
Well, we're going to be doing a C-section, yes, but
I didn't mean a C-section. I meant an ultrasound.
yes, yeah, we want to get an ultrasound. You got it. Yep, we need to be able to see and visualize where this placenta is, okay? We cannot just diagnose a placenta previa based on, a speculum exam, or just that she's having bleeding. We need to get an actual anatomy scan or get an ultrasound to show us where that placenta is, okay? So we're going to get an ultrasound and we're going to avoid vaginal exams. So what are we anticipating our treatment plan to be for this patient on the previous slide? So we talked about how she's going to need a C-section. What happens if this patient that comes in who has bright red vaginal bleeding is only 30 weeks pregnant?
Bed rest.
Yeah, she's going to be on bed rest for sure. So if you have this patient in the hospital on bed rest since she was 30 weeks pregnant, what is her days going to look like? What do you need to make sure you do while she's in the hospital? What are we monitoring for?
Severe bleeding in case she needs a blood transfusion.
Yeah, we need to watch and see if she's bleeding, because not only if she's losing too much blood, but if she's bleeding to the point that this baby is at risk, we may end up just needing to deliver early and have NICU present. Okay. So we're monitoring the baby. We're monitoring her vital signs. We're monitoring to make sure that she's not increasing her bleeding or that she's not developing a placental abruption or anything like that. These patients that are on bed rest who are at a high risk L&D facility who are there for prolonged periods of time, these patients are getting NSTs sometimes twice a day. They're getting daily, almost daily ultrasounds. They're getting vital signs, Q shift or whatever it is. These patients are monitored very closely. Okay. If the patient is at term or over 34 weeks, we're most likely going to just deliver and have the baby. Okay. So she's going to get ultrasound, bed rest if necessary, monitor her bleeding, monitor fetal heart rate, monitor her vitals, monitor to make sure she's not having uterine contractions, and then we're going to notify anesthesia and the NICU team, because if we have to deliver, we need all these people to be there for the delivery. Okay. So you're going back for a C-section. Your patient is 36 weeks. She's having placenta previa. You are getting everything ready. What are some things that we need besides surgical consent? Think preoperatively. For a
She needs to
preoperative,
be prepped, like cleaned.
yep, we're going to clean her belly off, usually with chlorhexidine wipes. We'll also shave like any pubic hair that's up higher, because they're going to have to make that low transverse abdominal incision. What other kinds of consents do we need for this patient?
Blood consent?
Yeah, we need a blood consent. What else? What other kind of consent? We're going to need anesthesia consent, right? For C-section. So we're going to need the anesthesia provider to have consent. We're going to need to make sure we have those IVs in place, probably 2 large bore IVs, because if she's having a placenta previa, that means that she's bleeding, right? So we're going to anticipate needing to potentially transfuse or at least give volume expanders, potentially albumin. So for our baby, we already talked about needing NICU there and needing anesthesia there. Who else would you want there for the baby?
Respiratory, maybe?
Yeah, respiratory. Definitely. Who else? Like, we need our neonatologist, right? We need our baby doc there, because they're going to be giving you all the orders when we have to resuscitate this baby. So we're not doing any vaginal exams. Type in cross-match blood products on hold. We have our IVs, C-section if indicated. Okay, so that's everything. I want to make sure you guys get this written down. That's everything we need to take into consideration whenever we're taking care of a patient who has a placenta previa. Okay. This is not a patient who can deliver vaginally. This is a patient that is most likely going to be going back for a stat C-section depending on her gestational age. Okay. Next question. A woman who's 32 weeks gestation experiences a sudden onset of intense localized abdominal pain with dark red vaginal bleeding after falling down the stairs. On her arrival at the hospital, her fetal heart tracing shows late decels. What condition should be assumed unless ruled out?
Placental abruption.
Yeah, this is your placental abruption. Okay. So, placental abruption is typically something that happens as a result of a trauma or impact to the abdomen. Okay. So, a motor vehicle accident, falling down the stairs, domestic violence if the mom has gotten severely pushed or hit or something like that, any type of accident. The other thing that can cause placental abruption is cocaine or drug use during pregnancy. Okay, if a mom is using cocaine or methamphetamines, during her pregnancy, this can cause placental abruption that we need to be careful about. In this picture here, we can see this picture is really good. So you see her placenta, and you see here how it's tearing off from the endometrial lining. So it is trying to develop, right? So then this is all blood right here. Okay, so this mom's belly is going to be super firm to the touch. She's going to be like in excruciating pain, like the worst pain that she's ever felt. She's going to have that dark red vaginal bleeding. Okay, that's how a placental abruption is going to present. Is this an emergency?
Yes.
Big time. Unfortunately, with placental abruptions, whenever a mom gets to the floor, if it's something that she's already had, we needed to have had a C-section probably 15 minutes before she got admitted. Okay, these are very, very emergent situations because mom is losing all of this blood. So baby is also going to be losing blood, losing circulation, and they're going to be hypovolemic upon delivery. Okay, so what's happening to our mom is happening to our baby, right? So this baby is going to be in distress. What route of delivery are we going to anticipate with the placental abruption?
C-section?
Yep, we're doing a C-section. This patient cannot deliver vaginally. We are emergently going to be taking this baby. So like I mentioned, your baby is going to be in respiratory distress. So what all do you want, or who all do you want in the OR?
Everybody.
Everybody. You're calling everyone, okay? So like one time I had a patient, well, we got a call from a squad that, and this was when I worked in Amish country, that a mom had been out in the barn and had gotten like kicked or something by one of the animals in the barn. And she was bleeding profusely, had the rigid board-like abdomen. So we didn't even prep a room. She came straight from the squad into our OR from the table to the operating table, and we had that baby out. That baby needed full resuscitation because they're so hypovolemic that mom has lost so much blood, baby is losing blood. So with hypovolemic infants or with babies that our mom has been bleeding during labor, these babies are going to need fluids. Okay, so we typically give them the D10 is what we give babies to help resuscitate them. But babies that are born from a placental abruption oftentimes need full resuscitative intervention. These babies come out and they are very, very sick. Okay. So I'm going to send this in our course cafe to have you guys practice. I want to keep moving because I want us to be able to play a little bit of Kahoot. So our goals whenever we're talking about placental abruption is we need to control our bleeding and prepare for a C-section. We're calling in the OR team, we're typing and cross-matching our blood, and we're going to have our uterotonics ready, which is those 4 medications we talked about that help the uterus gain tone. We're going to prepare for mom having a hemorrhage. So get our 2 large bore IVs, maintain her stable vital signs, give IV fluid and blood products because we want to maintain our tissue perfusion. And then we're monitoring for signs and symptoms of that hypovolemic shock like we talked about earlier. So mom is going to show signs of having that high heart rate, hypotension, dizzy. She's going to be dizzy and lightheaded, confused, have pale skin, low urine output, and cool and clammy skin. Okay. Monitor for signs of DIC. All right. So let me pull up this Kahoot. We're going to play here for the next 15 minutes or so, 15, 20 minutes. And then you guys will be good to go. Has everyone played Kahoot before? You guys know how to do it? All right. All right, let me share my screen here. And we'll get started. I'm not sure if everyone's going to be able to join. I think there's a limit on the amount of people that can join. So we'll just go until it tells us we have to not let anybody else in. And then if you guys aren't in the Kahoot, you can still follow along because you'll still be able to practice and answer the questions. You just won't physically be on the screen. All right, let's go ahead and get started because I think this is the amount total that we can have. All right, our most common non-obstetric surgical emergency during pregnancy is appendicitis. So anytime we are considering having a patient who's pregnant go under general anesthetic, we really need to make sure that there's a good reason that we're doing that because putting a mom under general anesthetic is not safe necessarily for her or baby. So appendicitis is the number one thing that is an emergency that we would actually do surgery for during pregnancy. So this is a cerclage. So if we are suspecting that mom has cervical insufficiency or she is going to be at a high risk for having a preterm delivery, providers can go up and suture closed the cervix. Okay. This is typically done in the early second trimester to prevent mom from going into labor too early or too soon. So it physically prevents the cervix from dilating or making any change. This one is a hydatiform mole. Okay. An ectopic pregnancy is when the fertilized egg implants somewhere other than the endometrium in the uterus. This is a complete placenta previa. Yep. When you see the words like totally covering, that means it's a complete placenta previa. If it were to say like it only partially covered the cervical os, then that would be a marginal placenta previa when it's not fully 100% over that cervical opening. But in this case, this would be a complete placenta previa. Pyelonephritis is a serious medical complication. Do you guys remember like what our signs and symptoms of pyelonephritis are?
Isn't it like fever, abdominal pain?
Yep, they're gonna show signs of like being having a kind of an infection. Yeah. So those are things that they're gonna have the high fever, chills, nausea, vomiting, intense like flank or back pain. So those are things that we're gonna educate our patient on that if they're feeling them, they need to come in to be seen. So this is severe preeclampsia because you see how it says that the blood pressure is 160 over 110, so that's severe hypertension. And then it also says that it may include symptoms of organ involvement. So, like, what organ do we see involved if we are looking at our labs? What labs do we care about?
Liver.
Yeah, we're looking at our liver function tests, so our AST and our ALT, and those are going to be elevated in the case of preeclampsia. So, whenever you see a blood pressure and also some organ involvement or other symptoms, we're thinking severe preeclampsia. This is HELP syndrome. So I didn't talk about it in class today, but I do talk about it in my recorded lecture. HELP syndrome is a variant of severe preeclampsia, and whenever we're talking about HELP syndrome, it's characterized by specific lab values. So we see hemolysis, elevated liver enzymes, and low platelets. It literally spells out HELLP. So that's kind of like the cheat code for how you can determine that. So this patient is now eclamptic because you see at the end it says that she has a convulsion. So she has a seizure. So she shows all the signs and symptoms of preeclampsia, but as soon as a patient has a seizure or displays seizure activity, she's immediately diagnosed with eclampsia. Mag sulfate. Yep, you guys all got it right. Awesome. This is the number one prevention for seizure activity. Methotrexate is the medication that we can give to patients with an ectopic pregnancy as long as they are not very far along. Okay, this is going to help break up those dividing cells and prevent the developing cells to grow too big and potentially rupture the fallopian tube. Getting tricky with the terminology up in here. Yeah, euglycemia is the term for what a normal blood glucose level is. Macrosomia is our big baby, and that is a birth of weight greater than between 4,000 to 4,500 grams. Birth weight greater than 4,000 to 4,500 grams. Really big baby. Bell palsy. Great job, guys. Placenta abruption. So that is when the placenta detaches from its implantation site. DIC. This is DIC. That is the form of clotting that's diffuse and consumes large amounts of clotting factors, causing widespread bleeds. Polyhydramnios. Yay, everyone got it right. Yep, excessive amniotic fluid, polyhydramnios, which we now know is common in our gestational diabetic moms. Iron. Yep, if your hemoglobin is low, it's usually a result of having not enough iron. Okay, last question here. Cardiac decompensation is the inability of the heart. Ooh, what just happened to my screen? Inability of the heart to maintain sufficient cardiac output. Awesome. Okay. All right, you guys. So for this week, you have your OB math assignment that's due. You also have your sim chart assignment that is due by Sunday night. Okay, like I said, I'll have that rationale posted for you late Sunday night, Monday night-ish, with all the answers for your OB math problems. Okay, I sent out emails this week to students who had KGAs in the class lower than a 78%. If that applies to you and you received one of those emails, please write me back so that we can schedule a meeting. I'm going to be making the exam for exam 2 this weekend. So if anybody wants to meet with me before the exam so that we can go over like key concepts to study, study techniques, whatever it may be that you guys want extra help on, don't hesitate to reach out and we can get you on the schedule to meet with me for a couple minutes to go over and review for exam 2. Okay. Exam 2 has a little bit more application questions and critical thinking questions on it than exam 1. Exam 1 was mainly just like understanding the material, looking at the questions, the way that OB questions are formatted. Whereas exam 2 is going to have a little bit more application and critical thinking associated with it just because of the course content that we've covered. Okay. So if you want to meet with me prior to exam 2, I don't think that would be a bad idea, especially if you didn't do as well as you wanted to on exam 1. Okay. But like I said, I'm going to let you guys out of here early because we did not have our break, our full 15-minute break today. If you have any questions, please feel free to stay after class and we can go over some things if you need. Like I said, next week we're going to have a quiz at the beginning of class, so make sure you're here on time. But if not, you guys are free to go, okay? Have a great rest of your week, and it was great seeing you all.